Thank you, Acting President. I guess I'd like to talk a little bit about sort of the Kensington experience in this matter because I've been a resident there for 30 years and the Kensington Community Health Centre has been a part of that community since 1975, continuously. I'll come back to the history and the nature of the organisation in a minute, but I guess the meeting we had on Saturday morning was on very short notice. It was 10 o'clock in the morning, which is a terrible time to do a community meeting. We still had a couple of hundred people there, packed into the Holy Rosary School Hall. And they were thoroughly outraged and frustrated. And I think in large part that was due to the fact that the communications from Cohealth was atrocious, to the point where both staff and patients found out about it from The Age, from the Herald Sun, from the ABC, from their neighbours, but not from Cohealth. No rationale, no FAQs. And going hand in hand with that was the entirely opaque decision-making process. And as Cohealth has grown, so too their governance structures have changed, and they've gone from roughly half professional and half community voices to a self-selecting board that perpetuates its own wisdom and invariably narrows its scope. And I think the way in which this has been handled is just an indictment on the current organisation. They really need to take a good hard look at themselves, because there are so many distressed people that having a simple discussion is extremely difficult. Now, as I said, Dudagala Community Health Service, the Kensington Community Health Centre was set up in 1975. My first involvement with it was in about 93. I think I was working for the Health Services Union and I got a phone call from the union rep saying they're forcing us to merge with the Flemington Community Health Centre. We've put a ban on the CEO, we've cut off her communications, we've set up a picket line out the front. Can the union send someone out because we need to know what to do next? Which I thought was pretty damned impressive. But it is a spirit of fight that has been within these community health centres for more than 50 years. And when they were merged into Dudagala Community Health Centre, there was argy-bargy and bit of aggro, and then that in turn ultimately got aggregated into Cohealth. And Cohealth do some great work. They have some innovative programs. They have a lot of incredibly skilled, talented and committed staff, many of whom feel betrayed by this. More than that, in many of these suburbs, the community health centres, it's part of the fabric of the community. You know, it's something that people come to rely on. And particularly in Kensington, where we've got a large public housing cohort, and the Kensington Community Health Centre also services a lot of residents from the Flemington flats and some from the North Melbourne flats. So it's got a big catchment, and its books have been closed for years. Literally one in as one dies, or moves away. It's that tight. And it's also a testament to how good the service is and how restricted the resources are. And if we look at who's, for example, in the Kensington public housing estate, or the Kensington estate, we see that there was put in by the government, a Labor government at the time, specifically an older person's block. So we've inherently got older, complex patients. It's also a first port of call for refugees, many of whom have been through horrendous life experience prior to coming here. And they get dropped into Kensington, and up until now, they could look at a sort of suite of wraparound services from primary health through to allied health and such like. So this is a really important part of the community. And to have the rug so suddenly ripped out from under them is horrendous. Now, my understanding is that of the 55 roughly community health services around Victoria, only 7 of them now offer GP services. So it is a dying trade. But in those neighbourhoods and in those catchments where we are talking about older and often more complex clients, the sort of wraparound suite of services that are provided are critical, not just to caring for those people in situ, but also preventing, as has been alluded to before, admissions to hospital and to other health services. And when we look at an organisation like this and we hear the state government saying, oh, we only do capital works, and the Fed saying, well, yeah, we do Medicare, but their model doesn't work with us, it's not good enough. From a state point of view, there's something like 80 programs that are run through and funded, many of them are state, and you can't just tease out one service or another, particularly if you're offering a wraparound suite of services. The other thing is that what Cohealth does is it has its doctors on salary. And those salaried doctors are fantastic. But of course, if you look at, for example, the recent Medicare bulk billing incentive from the Feds, it was targeted particularly at places where you're not dealing with salaried medical officers. You're dealing with GPs who are doing a bulk billing service, and a bit under half goes to the service and a bit over half goes to the GPs. And at Cohealth, that doesn't happen because they're salaried. So that's a problem as well. So if we have this rug pulled on the GP services, it's like pulling one thread in a jumper, a woolen jumper. It's all going to unravel, and the quality of care and support provided will inevitably be fundamentally reduced. So in that context, we support the motion that's been moved by the Greens. We thank them for kicking this off. We indicate that this is a really, really important issue for the communities that are directly affected. And I think everyone is very committed to fighting it. Kenny and Flemington, we've always been fighting. This will just be another encouragement and the next campaign, because this is worth fighting for. The community is committed to getting this change. And I would call upon the Health Minister at a state level. I would call on the Health Minister at a federal level to come together to reach some understanding about how funding shortfalls can be addressed and how the structure of Medicare incentives can be tweaked to allow for the models of care that are premised upon quality time with patients over a longer time frame can be maintained, and that suite of wraparound services can continue to be provided to the communities concerned. Thank you.